And next, we'll go on to Kiran, Chief Inspector here. And Phaco versus phacotrabeculectomy. The two surgeries that is used for closure when there is a cataract as well. Please go ahead, Kiran.
Thank you. So, cataract, phaco, glaucoma, trab. So, naturally, logically, in a patient with cataract plus glaucoma, you think phaco plus trab. The problem is, we were talking about complications of clear lens extraction or cataract extraction, but you introduce trab to phaco, you are introducing a whole host of complications that may range from minor things like a slow visual recovery compared to phaco alone, but it can have major complications like hypotony-related complications and nuisances for the patient and the surgeon that includes needling, suture lysis, and basically once you add trab to phaco, the wow factor of the phaco alone is lost. That is why almost all glaucoma surgeons have gray hair. What is the effect of cataract extraction on the angle of the eye? So this is an eye, angle closure glaucoma, already PI done. See the thick lens, the anterior chamber depth and the angle. And once you replace that thick lens with the thin intraocular lens, you can see the chamber deepening and the angle widening. The nerds in the audience can look at these pre-op values, anterior chamber depth and the AOD, TISA, all these are markers of angle. And you find that post-operatively, these values, even after a PI had already been done, once you perform a cataract surgery, undergoes a significant transformation. But these changes are not confined just to angle closure eyes. If you look at open angle glaucoma and control eyes, you can see here that the anterior chamber angle width and widening and deepening is found in all the three eyes, in open angle eyes as well as eyes with no glaucoma. Though the maximum change is seen in angle closure glaucoma eyes, but cataract does have an effect even on the other eyes. So what happens to the angle when we add trab to trab versus phaco alone? So preoperatively gonioscopy, this is the extent of synechial angle closure. A theory that earlier was present was that synechial angle closure is not going to change by performing a phaco alone. This study shows that it is wrong. Following phaco and following phaco trab, there is a decrease in synechial angle closure. But the extent of closure reduction is much more in the phaco alone group, which makes perfect sense because the widening that is caused by the phaco is counteracted by the filtration of the trab. The UBM studies are also very similar, that both these procedures do widen the angle. The widening is much more though in the phaco group alone. But the important question is, we are trying to treat intraocular pressure. So what happens to the IOP in glaucoma patients after you perform a phacoemulsification? So this is the ophthalmic technology assessment published almost a decade back, which is something like a meta-analysis. You find that on an average reduction of 13% of IOP can be expected in an open angle glaucoma eye by phacoemulsification alone. This increases to around 20% on average in pseudoexfoliation, and in angle closure glaucoma, you can on an average expect 30%. And even if you look at the postoperative glaucoma medication, you can reduce to almost 1 to 2 medications in angle closure glaucomas. But there is a subset of angle closure glaucomas that gives the maximum dramatic effect. That is the subset of acute primary angle closure, or what we call as an acute angle closure crisis. You can see that while there are only few studies in literature, the average reduction of intraocular pressure after removal of the cataract alone is almost 70%. So, but we want to know which of your patients, even if it is within the spectrum of angle closure, which of your patients are likely to benefit most by performing a phaco. That will also help us to tell the patient, okay, you are going to have some reduction of IOP, you are not going to have so much of reduction. But unfortunately, the only consistent predictor has been a high pre-op IOP, which is not going to be of tremendous use for us. Unfortunately, the other things like AC depth or the extent of synechial closure, the lens thickness, axial length ratio, the lens volt, all these parameters have not been very consistent predictors. So we don't have a set of parameters that we can look at in a given patient and tell them that, okay, you are going to benefit most from cataract surgery. Now we want to look at the complications when you perform phaco in a patient with glaucoma. So you have IOP spikes, and then the other is phaco-related complications. So certainly when you perform phaco in a patient with glaucoma, irrespective of the type of glaucoma, you are likely to develop IOP spikes, especially in the first week, which is higher than average. But phaco-related complications, because of improvements in surgical technology and so on and so forth, you find that it is not really much different. compared to performing phaco in a non-glaucomatous eye. Though we would have expected slightly higher numbers with angle closure glaucoma, the literature doesn't suggest so, which just shows how much phaco has improved in its safety. It is except in one honorable mention. Of course, in acute primary angle closure eyes, when you perform phaco, you will have higher rate of complications that ranges from higher edema in the cornea, AC reactions, and wound leaks, and so forth. So when you have both cataract and primary open angle glaucoma, the deciding factor whether you should go for phaco alone or phacotrab is pre-op control of intraocular pressure. If you have a medically controlled open angle glaucoma, you simply go and do a phaco alone. If you do not have a medically controlled open angle glaucoma along with cataract, you will have to combine phaco with some IOP lowering procedure, whether it is trab or more minimally invasive angle-based procedures, we can think about it. And an acute primary angle closure glaucoma with cataract, simply do a phaco alone. That is going to treat the condition more often than not. You will very rarely require a subsequent trabeculectomy. What about chronic primary angle closure glaucoma? Can I get away with phaco alone? So this is a study from L.V. Prasad in medically controlled primary angle closure glaucoma. You can see the two groups, both of them have similar success rates in terms of IOP control. But as expected, the phacotrab patients had a higher rate of IOP spikes, and one episode of malignant glaucoma also happened in this particular study. So in medically controlled primary angle closure glaucoma, it does not make sense to introduce more complications by adding a trab along with the phaco and just go ahead and do a phaco alone. But the question is, what about medically uncontrolled primary angle closure glaucoma? So you have a medically uncontrolled primary angle closure glaucoma. You can find that the phacotrab group, that is the dotted lines at the lower end of the graph, the phacotrab group did have lower IOP compared to the phaco group, though statistically they could not find it very significant. The reason why they could not find it statistically significant is because the phaco group still was on a larger number of medications. So one definite advantage of doing a phacotrab is you can reduce the number of medications quite significantly. But with some medication support, the phaco group also could achieve similar levels of IOP as phacotrab group alone. The problem again is that the phacotrab group certainly had higher rate of complication. There was even one case of wipeout, but other cases like needling, one patient required a revision trabeculectomy. So all these complications do happen more often in the phacotrab group. But also keep in mind that when you deal with such patients, around 15% of the eyes who underwent phaco alone needed a subsequent trab. So this is something that needs to be specifically discussed with the patient. If you are performing a phaco alone, that you might need trab later on, though we expect some reduction of intraocular pressure. So even in medically uncontrolled PACG, you can give a trial of phaco alone with some caveats. Obviously, as I said, all of them may not be able to get away with phaco alone, and we need to tell the patients beforehand that you might require a trab subsequently. And also, when you have a certain set of patients, for example, almost all these studies were looking at pre-op IOPs of around 25 or 20 plus or minus 3 millimeters of mercury. You have a patient who comes in with pressures of 44 with an extensive disc damage. You may not have the luxury of waiting for about 1 or 2 months before the pressure comes down, and in such cases we might have to do phacotrab alone. So except for those individual caveats, you might be able to get away with phaco alone in an angle closure glaucoma for good IOP control. Thank you.